Hello, everyone, and welcome to today's MinMD Real Talk webinar, Injection Therapy Online Clinic. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at MinMD, and I'm excited to be hosting this session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right, with that being noted, I'm pleased to introduce today's presenter, Dr. Daniel Martinez. Dr. Martinez is a fellowship-trained physician specializing in sexual medicine, andrology, and male infertility, and he's located in Miami, Florida. Today he's going to cover injection medication, syringe and dosing, injection techniques, support options, and then hold a live Q&A to close out the webinar. But before I hand the mic over to Dr. Martinez, I have a few housekeeping items to cover about this presentation, the MinMD Real Talk webinar platform. If you're joining on your laptop or desktop, you'll notice a control panel on the right of your screen. If you'd like to minimize your control panel, click the orange arrow at the top left of your control panel. If you're joining on a mobile device, your controls are at the bottom of your screen. As an attendee of this webinar, you've joined in listen-only mode. If you have a question for our presenter, please feel free to send it through the questions tab in the webinar control panel if you're joining through your laptop or desktop, or in the bottom tab if you're joining through your mobile device. We'll be answering all questions at the end of the presentation, but if we don't get to your question, we will be sure to follow up after the event. I'd like to also thank those of you who submitted a question with your registration. We have those all written down, and we'll be getting to those questions first during the Q&A portion of the event. We've also included a handout, which is our injection therapy guide. You can find and download this handout by navigating to our handouts tab on your laptop or desktop, or in the bottom tab on your mobile device. All right, and before we get started, we do have a few poll questions that we'd like to ask the audience, so we will go ahead and launch those now. All right, first question here is, how long have you been using injection therapy as a treatment option? We'll just take a few seconds for everybody to answer this, but it's going to give us a good idea of the type of audience that Dr. Martinez is speaking with today. Thank you, everyone who answered this. Looks like we got mostly some newer injection therapy folks with us, as well as some seasoned people as well. We'll move on to the next question here. Have you ever performed an injection on yourself and not received the desired results? Yes or no here? All right, thank you to everyone who answered this. Looks like majority have had an injection that did not give them the desired results. So hopefully by attending this webinar today, we'll be able to fix that and everyone will get the results that they're looking for. All right, last question here. Have you attended one of our previous MinMD Real Talk webinars? We hold these on various topics, and we've been running these since September of last year, so it's our one-year anniversary. All right, looks like we've got some new folks here, and thank you to those who decided to come back. So without any further ado, I'd like to kick things off by welcoming our presenter, Dr. Martinez. Over to you.
Thank you, Austin. Really appreciate that. Thank everybody for being a part of this. Thank you, MinMD. You know, I've been working with MinMD for close to, I think, since the inception of the company, really about close to 10 years. It's got to be now. And you guys have done such a wonderful job. I'd like to thank you, not just for hosting this and being able to allow this presentation to happen, to be able to provide knowledge and help these men and the partners understand what injection therapy is about, but also for treating my patients and all these men and women out there so well with providing such a great customer service, good products, economical. I mean, I have nothing but wonderful things to say, and that's why I've been so loyal to you guys for so long, because you guys do such a great job. So I really appreciate that. Thank you, Austin. Thank you, everybody else. So for those of you who don't know me, I'm Daniel Martinez. I'm giving a few talks through these sorts of webinars. I've hosted a couple of these. I think it's wonderful that we're able to do this, especially during such difficult times where in-person talks aren't really amenable, and we can't do it because of the social distancing. But this is great to be able to provide this avenue. I actually, interesting enough, this topic of injection therapy is extremely dear to my heart. I got into urology and I did my first research in urology on injection therapy. I did it while I was at Boston University School of Medicine under Ricardo Munarriz, one of the gurus of the field. And so you can say that injections really who got me into urology to begin with. From there, I went on to do my residency and fellowship under the University of South Florida under another guru in the field, Dr. Rafael Karian, whose father actually was one of the first to create the penile prostheses and really brought organic treatments to the forefront for the treatment of erectile dysfunction, which some could say opened the doors to things like injection therapy. Currently, I'm in private practice, urology specialty care down in Miami. I am one of 4 urologists there. Again, bulk of my practice is sexual medicine, andrology, or that's issues with hormonal imbalances and male infertility. I have an affiliation with the Miami Cancer Institute where I run their sexual medicine, andrology, and male fertility programs. I have an affiliation with Baptist Hospital, Maine, in Miami, Florida. I'm the chief of urology there, and I teach residents. I'm a clinical instructor for FIU, Wortham College of Medicine. So what are we talking about today? Well, we're talking about a topic that's very dear to everybody. Let's face it, sex sells. Sex is it's exciting. Sex is extremely important. As a matter of fact, sex really is what brings men to the doctors. It's all fun and games. Everywhere you turn, you see things about sex until something goes wrong, of course. And every man, unfortunately, will develop some issues with erections, which is the bad news. But the good news is that I tell every man that comes to see me, they're going to have sex until the day they die. And that's because we have such great therapies, such as injection therapy, and that's going to allow the man to be able to have an erection that's rigid and sustainable enough for the entirety of sexual intercourse. That's the good news. So how do we get an erection? Really, the stars have to align. The penis is a fascinating organ in the sense that in order for it to function appropriately, the stars have to align. It's a multifactorial process to be able to have an erection. You got arteries, you got veins, you got nerves, you have muscle, smooth muscle, you have an architecture that has to work a certain way, you have the hormonal mixture as well. And it all starts with stimulation. When a man has some sort of stimulation, their body produces nitric oxide, which ultimately then will begin to allow the bloods to dilate and blood to flow into the penis through the cavernosal arteries. You'll see this is a cross section of the penis, and it almost looks like bug eyes, a bug's face. You know, the 2 big eyes and then the mouth. Those 2 big eyes are what we call the corpora cavernosum. These are these cylinders that fill up with blood, and that's what allows a man to have an erection, rigidity erection. You can see the little thing through the middle; those are the corporal arteries. So as blood flows in, because the smooth muscle relaxes, allowing the blood to flow in, it makes the penis stiff and hard. And you got the tunica albuginea, which is the surrounding structure. It's the second toughest membrane in the body after the dura of the spinal cord. That's what holds everything and maintains it nice and tight. In addition to that, all the veins then, they tighten up and it almost acts as a dam. They close off the outlets and don't let the blood leak out. And so that will then hopefully provide an erection that is rigid and sustainable enough for the entirety of sexual intercourse. Once a man orgasms, then what happens now, some other enzymes are released. This process begins to reverse. The veins begin to open up. The dam opens, we'll say, and the floodgates open, and the blood starts to flow back, and you then become flaccid again. So this is the process of how somebody gets an erection. Of course, like I said, it's all fun and games and great until something goes wrong. And that's when then I get men to come to my office because now they're having difficulty having erections. And again, I think that first slide, which speaks of the importance of seeking medical help, because most men may not seek medical help until they have a problem like this. And there may be some other underlying issues. So remember, all you guys that are seeing this, if you're having this problem, but you haven't gone to see your primary care or your cardiologist, etc., you may want to look into that because there may be some other things, and this may just be a precursor to some more serious problems that might happen. So intracavernosal injections is what we're going to talk about today. This is what it looks like. It's a needle. It's one of the oldest forms of therapy. It's been around since the 1980s. So the only thing older really is the penile prosthesis, which came out in the 1970s. The 80s, the story goes, and this may be myth, but I've actually spoken with some urologists who claim they were there for this. But the myth is that the first study, or the urologist that first studied this at a national or international meeting, the way he showed everybody in the crowd that this stuff works is he literally dropped his pants, grab his penis, inject himself, and give himself an erection in front of everybody so they can see the efficacy of this treatment. So that's dedication, to say the least. So how is it that these medications work? And when a person comes to see me, my job is, I tell everybody, I'm the guide. I'm here to guide them. The patient is the captain, and there are different treatment options. And really all these options, what they're doing is they're trying to increase blood flow into the penis. Not only increasing blood flow, but trying to get it to a point where to give you an erection that's rigid and sustainable enough, but you want to also maintain this, not just get erect, but stay erect and be rigid enough to be able to do it. So these injections are usually a combination of different medications. There's 3 medications in particular: prostaglandin, papaverine, and phentolamine. You have 2 types of mixtures: bimix, which is a combination of papaverine and phentolamine; trimix, which is a combination of all 3: prostaglandin, papaverine, and phentolamine. And so that's incredibly important to understand that, because these mixtures really is what makes these medications not only so efficacious, but very tolerable. The bimix, like I said, is papaverine and phentolamine. You can see on the one side of the screen the different mixtures, and really this is where the art form comes in to play. When somebody comes to see me and we start them on these medications, I do a penile Doppler, which is an ultrasound of the penis on everybody. And I really do it for multiple reasons. Number one, to show technique, because I actually give an injection. So the first injection should be done with a urologist, not just a urologist, somebody who feels comfortable and is trained to be able to do this. I teach technique, and based off of the results I see on the Doppler, on the ultrasound, that tells me at what concentration I can start somebody. So do I need to start somebody on the weakest, let's say a bimix number 3, or can I take him to, or do I have to take him to a trimix number 12, or a trimix 16, or a bimix 10? This is really where the art comes into play. Trimix, as I stated before, has the added alprostadil or prostaglandin, so it's 3 instead of just 2. The beauty of this is prostaglandin, which is a very vasoactive substance, but it burns a lot. When you mix these other medications, well, that all of a sudden allows you to have the same efficacy, but a little more tolerable. And so that's the beauty of these medications, is that you have all 3, and so you now have something that works well, and is very tolerable. It tends to have less of that burning sensation, which is always a complaint when people were just doing the pure prostaglandin. And again, you can see here the different mixtures. I, as the urologist, control the concentration, so the mixtures. The dosage, or how much you're injecting, is controlled by you, the patient. We also control the needle size. These are the needles, the traditional needles that we use. These needles are very similar to the ones that are used for insulin injection. You'll see the numbers from 10 to 100. If you fill this all the way to 100, it really only holds 1 milliliter of fluid, which is not a lot of fluid. People worry and say, "Oh my goodness, I'm going to inject a lot of fluid into my penis." No, it actually is it's just 1 milliliter if you fill the whole thing, and most guys will not need to fill the whole thing. They're only going to use a little bit. So 10 units is 0.1 milliliters, or 0.1 cc's is another nomenclature that we use to talk about the fluid volume. Okay. So the needle itself is extremely tiny, very thin. We can control the gauge, or the thinness or thickness of the needle, and the length. And then, of course, the dose is controlled by you, the patient. And we always say start low. The first time you inject, you're going to probably start with 10 units. And you can work your way up little by little until you're looking for a goal. And the goal here is an erection that is rigid and sustainable enough for the entire sexual intercourse every time you want it, but lasts less than an hour. So again, the first dose should be done by a urologist, not only a urologist, but somebody who does a lot of these, who feels very comfortable with this. Why is that? Well, because people can have different reactions to it, including also an erection lasting more than 4 hours. That famous priapism that everybody always laughs about. I tell people, well, that can happen. They say, oh, that'd be great, that'd be wonderful. Well, they're not laughing when they figure out that they have to go to the emergency room and have to be treated for that in order to reverse it. So it should be done by somebody who's experienced in this. You're looking for this rigid erection. You see the rigidity scale from 0 to 10. You want to have that's rigid enough, firm enough to be able to penetrate, and something that lasts long enough but doesn't last too long. And so you always want to start off with 10 units. The first time somebody injects, which would be just a few minutes before intercourse, they would inject the penis, and we'll go over a little bit about the technique in a second. They'll inject, then they'll try to have intercourse. If it's not enough, they cannot inject again. You should not inject again. So there is a little bit of trial and error, especially in the beginning. You have to wait at least 24 to 48 hours. Then you can inject again. This time around, you can go up in the dosage. And again, it's a slow incrementation until you get to a point where you get that erection that you're looking for. So again, most doctors don't recommend injecting more than 3 to 4 times a week. What I tell people is you can inject every other day. So that would be the maximum amount that you can inject, okay? These are some ways to log your progress. Ultimately, when I see somebody and we start them on injection therapy, I always see all my patients every 4 to 6 weeks until we get to a point where they have an erection, again, that's rigid and sustainable enough for the entire sexual intercourse, but lasts less than an hour. No more marathon sexing, guys. And one of 3 things will be said to me on the following visit. Number 1, I use a small amount and it worked great. 10, 20, 30 units, awesome, worked great, lasted less than an hour, done. We're good, see you in 3 to 6 months. Number 2, I used a lot, 80, 90 units, and it worked great. Or I used a lot, 80, 90, 100 units, and it didn't work. If that's the case, we can always change the concentration and give you a stronger medication. So how do you prepare the medication? And then we're going to go through a demo. You can see here that vial is it's going to look just like that. That's what's going to have the fluid. This is a vial that you'll be able to use multiple times to be able to suck out the fluid. Again, you want to go for those lower volumes so that it lasts you longer. Then, of course, you have the needle, which we talked about already. You have 3 things that you'll receive: the medication vial, the syringes, and then alcohol preps, which you'll use to clean the vial and also clean your penis before you inject. So how do you do it? You take the vial and the needle. The vial will have a cap initially, which you can take off. The needle will have a cap on both ends, one on the plunger, one on the needle. You take the cap off the plunger, you take the cap off the needle, you clean the actual vial. You will stick then the needle into the vial after sucking out or pulling the vial, the plunger back to get some air in there and to get to the desired volume. You will then stick that needle into the actual vial. You'll flip it upside down. You want the fluid to be the vial upside down with a needle like this. You'll push the air in so that you know that there's no air in the actual needle now, and then you suck back to the desired volume. Pull out the needle, you tap it to make sure that all the bubbles are gone. You can always push out a little bit if you have some bubbles, and then you can go and inject. How are you going to inject? So this is where the art or the technique will say that for me, it's just become secondary nature because I do a lot of these and I do a lot of Dopplers, and so I see a lot of patients. And it does take some getting used to, but most guys get this fairly easy. This is the importance of also having it done first at the office so they can see the technique. The first thing you're going to do is, of course, you're going to grab your penis by the head, not the prepuce, not the glands, or not so much the glands. I'm talking about the body, the shaft of the penis. You grab the head of the penis and you get an anatomical position. What's anatomical position? Grab the head, pull it out, straight out. You don't want to twist the penis, because you twist the penis, now you're torquing the penis, and the top might be the bottom might be the top, the side might be the left. You want to keep it so that you're in an anatomical position, penis straight out, not turned from side to side, okay? And the injection is going to be, this is the penis, right on the side of the penis, close to the base, okay? You can see here, this is a cross section of the actual penis. So again, the bug eyes that we talked about, that's that corpora cavernosum, which is the cylinders that fill up with blood. If you're looking at this like a clock, and you see the 2 X's on the top and the bottom, that'd be 12 o'clock, that'd be 6 o'clock on the bottom, 12 o'clock on the top, 6 o'clock on the bottom. You want to go on the sides. So you want to go 3, 9 o'clock or 2, 10 o'clock in order to be able to inject. And again, we'll go over this a little bit more when we do our little demo. You'll see it makes a little more sense once I show it to you. After that, you push the needle all the way in. Don't, not just a little bit. You want to push the whole thing in. Everybody's always a little bit scared, but it'll actually hurt less if you put the whole needle in. It's not a very big needle, not a very long needle. Once the needle's all the way in, you push the fluid in, take it out, hold a little pressure there, especially if somebody's on aspirin or Brilinta or Plavix or a blood thinner. And after just a few minutes, which you're going to inject a few minutes before sex anyway, so you need something to do, you'll hold it in there, hold a little pressure, let go, you go to have sex, okay? One other thing, the penis has some veins superficially. These veins should be easily manipulated and move around. Be careful, you hit a vein, not the end of the world. You'll have a little bruise, a little hematoma. The joke is the penis may look like an eggplant. It'll get better, it'll go away, you'll have your normal penis again, okay? So how do we mitigate some of these side effects? Again, proper technique is important. I go over technique. It's incredibly important even in the follow-up. You may have the most perfect experience with the injection, but it's important to go over the follow-up again, and I give people in a fake syringe and I say, let me see your technique, and we tweak it. If somebody comes and says, I have good times and I have bad times, that's typically a technique issue. And so again, that's the importance of going to see a urologist that feels comfortable doing this, because you want somebody to be able to guide you here. Again, I tell people, I'm the guide, you guys are the captains. Rotate sites, so you never want to do the same place all the time. Become ambidextrous. Eventually, you'll get real good at this, right and left side. You can go anywhere really on the shaft of the penis, never the head, never the glands, but the side of the penis is fine. And again, you don't want to inject more than once in 24 hours. Again, every other day typically is what we recommend. Once you puncture these sealed vials, they got to be refrigerated. And after about 28 days, you should throw them out. Again, this is for your safety. So accessories, you can accessorize like anything in life. We're going to go over some accessories in a second before I then give you the, actually I'll do the teaching first of the shot, and then I'll give you some of the accessories, which are pretty cool. These are some of the accessories, the insult totes, little bag that it's nice because let's say you're going to travel somewhere, you can use this to be able to take the medication with you. You can put all these other things, the auto injector for some men, maybe some men that have a little bit of a tremble in their hands. The auto injector is a wonderful way of being able to inject themselves. The insole ease also for men that have some difficulty getting the actual needle in to be able to suck out the appropriate fluid, and then a sharps container, because you got to be careful. These are needles, and you want to make sure they're disposed of them appropriately. Again, MenMD, I have nothing but wonderful things to say about you guys. You guys have always treated my patients with incredible respect and a beautiful customer service job. You give them. You guys have a great amount of resources to be able to provide to these patients who are going through a very difficult time. And it's a great thing to be able to make them feel comfortable and provide them with a product and a service that's helping them be happier and healthier, of course. And so I applaud you, and this is just some of the websites that you can get on and the numbers to call to be able to talk to a clinical case manager. And of course, myself, if anybody's interested, I'm in Miami, Florida, very easy to find. Taking new patients, happy to see whoever's out there. I think some of my patients or some of the patients in my office are already on this webinar, and so it's good to have everybody to be a part of this today. Okay. All right, so we're going to go over real quick a little. Let's see. What I'm going to do here is I'm going to stop sharing my screen for 1 second. You guys should be able to see me, but we're going to go over a little demo now to be able to talk about it so you guys can see how to do this appropriately. What's the appropriate technique? Okay. So here we got the penis. Yes, this is one of the few webinars where this is an okay thing to have. So here's your model penis, okay? So when I'm talking about anatomical position, what you're gonna do is really, you're gonna grab the glands, and so I tell guys, grab your glands, and you're gonna pull it out as far as you can, okay? You don't wanna torque the penis too hard because you're gonna end up, of course, injuring yourself. But you pull it out as far as you can. You don't wanna twist it, because you twist it, now all of a sudden, the anatomy gets distorted, okay? So you can see here the anatomy is getting distorted. So you wanna grab the penis, you wanna pull it out as far as you can so that it's an anatomical position, and you can see, not the glands, because you grab the foreskin, all of a sudden the head will pull back. And if your head pulls back, you may inject into the head, which number one is going to hurt, and number two, you're not going to get the desired effect. So you grab the head and you pull it out, okay? Once you're out, we're going to go over real quick the clock that we were talking about. Right here, this is the top, this is 12 o'clock. Right down here, which is the glands, this is 6 o'clock. So you got 12 o'clock, you got 3 o'clock over here on the side. You got 9 o'clock over here, okay? So 12, 3, 9, 6. All right, and ultimately the place you want to inject, like I said, is here's 9 o'clock, here's 10 o'clock. So 9 o'clock or 10 o'clock, all right? So 9 o'clock or 10 o'clock, you want to inject, boom, right in there. So one hand you're grabbing the penis and pulling it out, and the other hand you're injecting. Or on the other side, right here, we're talking about, that's 2 o'clock right there, or 3 o'clock, okay? And you don't want to do this, you don't want to do this, you want to come straight in perpendicular to the penis, all right? Here we got the syringe that we were talking about. This is your syringe. You can see the 10 to 100 on the actual syringe. Again, even if you fill this to 100, it's only 1 milliliter of fluid. We're not talking about a large volume, right? These are the two caps, the cap for the needle and the cap for the plunger. You take this off and you take this out, and you can see there's your needle. You barely even see it. So most guys, when they see this, this is the part they get a little nervous, or they walk in nervous. Once they see this and we do the shot, they say, okay, that's not that bad at all. So here's your desired effect, you want to pull it out first. There's your 10 milliliters, just the initial start. Always going to start off with 10 milliliters. And once you get good and you say, oh no, I use 30 to have sex, no problem. Get to your 30 or your 25, and you can use that whenever you want. But first, you pull out to get the air in. You're going to get very similar to this. This is pretty much how the actual medication will come. So you take the top off of this. You take the actual vial out. The difference, the vial that you will receive will have a cap that you got to take off. All right. You will then wipe this with the actual alcohol pad that is also provided. You're going to take this, you're going to flip it upside down. Why? So you got all the fluid on the bottom. I once had a guy that said this wasn't working for him, and then when I looked, it's because he was sucking air out. Okay. Want fluid in, you put the actual needle in. All right. Once the needle is inside the actual, so you got the needle in like that. All right. Once you got the needle inside and this is upside down, you push the fluid. Once you got fluid, or once you got air into the fluid, now you can start sucking back. Because now you know that what you're going to pull back is the actual fluid. So we're going to go to, let's say, 30 milliliters. We'll go to 20 here. All right. Once you got 20, now you pull out. You got your needle right here. Okay. This is the part now where you can tap the needle to get the air out as much as you can. You can always push up so you get some air out. Okay. You get some of the fluid out. You're going to grab your penis. Again, the technique is you grab the penis, you pull the head out. Okay. This is the part then, again, you're going to take your needle. You're going to put the needle right at that area. So let's say right here, we're going to go for about 10 o'clock. Boom. Push needle all the way in. So once you find your spot, you push it all the way in. Don't do it half. Just push the whole thing in. Once you're in, push the fluid in. Once you got the fluid in, take the needle out, put your needle down. Be careful not to injure anybody, and just hold a little pressure. Okay. Remember, you want to be careful of the superficial veins. Hold the pressure for just 2-3 minutes. Once you got that and you're ready to go, you can go ahead and have intercourse. Okay. So this is the technique. Again, for me, this is something I do every day, but this is something that you want to have the first one done with a urologist. You're going to want to have to go over this a couple of times just to make sure you have it right. All right. Again, you can inject anywhere in the shaft of the penis. The first time you want to do it close to the base, anatomical position when you're holding the penis out. Stay away from the 12 o'clock and 6 o'clock position. Okay. So that's your injection. Now, some of the accessories. So here's your tote, and there's the tote. You see the stuff inside, and here's the sharps. Of course, you want to put the injection, once you're done, the needle back into the, never want to reuse the needle. So you will be getting needles from NMD as you order from them. Here you got the tote with I put a couple things already in here, medication. You got the place to put needles. This is an auto injector, which is really nice. For the auto injector, we'll go over a little technique here of how to use the auto injector. Okay. So the auto injector will come with a couple different ones of these. This is really for different needle sizes. For the most part, you're going to use the one that's 101.0 milliliters. So that goes on the tip there. There's a little clear thing you can take out, and you got right in there, this little hole is where you're going to put the needle into. So the first thing you're going to do is you're going to pull this out to arm it. All right. There's a button on the side. This is how you actually shoot it. So the first thing you do is you pull it out and it's armed. All right. So you can see the thing just pulled out. If you pull this down, now all of a sudden you make that hole nice and big. And why is that hole big now? Well, because now we can take our needle. So here we go. We use the needle. Although I told you not to use the same needle again, we're going to use this one again. And once you got to take all the fluid out of the needle first, okay? So you fill it up the way you would if you're going to do it by yourself by hand. You then will put the needle right in there, okay? You got it right there. So now this thing will fit right into that little hole. And once you push that forward, now it locks into place, all right? So unlocked, locked into place, all right? Now you got your needle that's in place. It's ready to rock and roll. Nothing's sticking out yet, all right? So this thing's like a pen. You're holding it, and you got the button that's right here that you're going to be able to inject with your thumb. And you hold it like this, okay? Grab the penis again. You're going to put it same position, all right? You want to put it right there, hold it. You want to hold the penis in the anatomical position. Press the button, boom, it gives in. Once it goes in, the needle goes in. Once you're done, pull it out, hold your pressure, and you go do what you got to do. To take it out, be careful because now you got the needle sticking out from there. You pull it out again, you open it up, take the needle out, and you can discard in your sharps. You're supposed to put this, well, you can put this once you got it in. When you're done, and once you inject it, you can put this back in like that in order to be able to put it away wherever you're going to put it away. So that's pretty much it. That's the demo. I think I'll turn it over now back to Austin to see if there's any questions.
Boy, oh boy, do we have questions. We've got a bunch. So I appreciate, like I said in the beginning, we had a lot of people submit questions during the registration portion. So we will go ahead and kick off. We'll start with those. And the first question is, why would the skin covering the penis be swollen following injection and stay swollen for several days after?
So the swelling of the skin can be one of two things. Number one, if you didn't get the needle all the way in, that's actually the fluid that just stays under there. So that will go away as well. That's the importance of when you push the needle, when you put the needle in, you got to put it all the way in, make sure that the needle breaks into that corpora cavernosum and not just under the skin, because then you just have some fluid in there. The more common thing would be a hematoma or a bruise. So if you have a bruise, like I said, don't freak out. I've had guys even show up and their penis looks like eggplants because it's swollen and bruised, but it'll go away. Some guys can use some ice. Just be careful not to put it directly on the skin. So typically hematoma and or the fluid itself, the medication itself that's just stuck under the soft tissue is this bump that you'll see when you're doing an injection.
All right. What's your opinion of centers that advertise the wave therapy to help blood flow? How effective are they, and do you recommend them?
At this point, so the American Urologic Association, so, the reason I tell people I'm the guide and they're the captains because I'm really just guiding them through the guidelines that are created by the American Urologic Association, which is really the governing body that tells us how we should practice urology, practice medicine. And really right now, we know that these lithotripsies or these different therapies that are out there are experimental. A lot of these places, the recommendation is if you're going to do it, you go to a place that's actually doing a clinical study. A lot of these places, it's cash pay. We don't have good data yet to support whether it works or doesn't work. We don't know the specific efficacy, and we don't know the true how often we should be doing it, at what frequency of the actual lithotripsy. And so they're saying it's not recommended at this point unless you're doing it in a clinical trial until more data is collected and there's an actual protocol to follow.
All right, next question here. I get a burning sensation sometimes and have swelling. Is that due to bad technique, or do I need to tweak the medication mix?
Either one it could be. That's the importance of the follow-up. So the burning, depending on the burning, initial burning, if it's burning that lasts a little longer, it could be the medication, especially the prostaglandin that's inside the medication. So that's something you may want to tweak. Maybe pick a mixture that has less prostaglandin and more pentolamine papaverin in it. Could it be just bad technique? Absolutely. That's why it's so important to do the follow-up and to see and go over the technique a couple times, because as I said, I do this all day, every day. And so for people who just, this is the first few times of doing it, you really want to go over the technique and make sure. If not, next step would be to look at the concentration and the different mixtures and maybe pick something that has a little less prostaglandin in it. Now, this is of course assuming that the erection is not lasting more than an hour. Because if you got burning because your erection, your penis is erect and rock hard for 3 hours, guess what? That's just because it's a priapism, and you need to just cut back a little bit on the amount that you're injecting.
All right. What are the long-term risks of using injection therapy?
So the more common thing that we'll see long-term is scar buildup, or plaque buildup in the actual penis. Every time you stick a needle, of course, it's traumatic. This is the importance of the movement. Don't just stick the same place, same place, same place, same place, same place. Go left, go right, go a little more distal, go a little more proximal, go a little more distal, go a little more proximal, and that should mitigate that risk. One of the more common risks that we see is scar buildup, or Peyronie's disease, that somebody can develop, which is a plaque of the tunica albuginea. Long term, there's no poison. You're not going to have liver poison, kidney poison. Of course, it may stop working at some point because erectile dysfunction is a progressive disease. Unfortunately, as we get older, it does get worse. But there's no real long term. As long as you're doing the appropriate technique and you're spreading the love, as I said, you should be okay. And following the rules, you should be fine.
All right. Next question here. Now that I started with injections, I can't get hard without it. Will I need injection medicine to get an erection full time now?
Yeah, and it's not because the answer is yes, more than likely. That's a very loaded, complicated question because there's a couple different theories out there that we follow and we know are true. For example, the theory of rehabilitation. So somebody can rehabilitate their penis, in other words, regain what they've lost. Now, I just told you that we're all doomed as men. Now, the bad news is we're all going to end up with erectile dysfunction. The good news is we got a lot of treatment, so you're going to have sex until the day you die, but you can't there's no way for me to give you that penis shell when you're 18 years old. It's impossible. It doesn't exist anymore. So we know that if a man goes a long time or has, let's say, a prostatectomy or some treatment that's worsening the erectile dysfunction, once you start having better erections, your penis will rehabilitate itself. Now, unfortunately, your penis and the erections will get worse over time. In addition to that, you know, the erection or ED, erectile dysfunction, is bad enough that what you need is the injection therapy, then yeah, that's just because your erectile dysfunction that's what it needs to be treated. Not so much because you started it, not because you started it, you need it. No, you started it because you needed it, and you're going to continue to use it because you need it. Not so much because the medication that you start, now you grow tolerance, and your body needs it because if you can't do without it. You weren't going to work without it anyways. So I hope that answers the question.
All right. Next question here. I keep getting conflicting information on injections and oral ED medications. Is it safe to do them together at the same time? And what's the benefit of this combo therapy?
It is safe. Now, again, the risk here, as I said, the injection therapy are much stronger, we'll say, than the phosphodiesterase inhibitors or the oral medications. I do have some patients that need to use both, or they find that sweet spot where they do a combination of the two. It's a little tough because now you're throwing a couple different things at them, and that's really where people they want to try to simplify what they're doing to be able to have intercourse. So to take an oral medication, which you have to take about an hour before, and then to be able to do injections and then have to do injections, which is a few minutes before, can it be done? Yes, but it has to be done in a very controlled setting so you don't end up with a priapism or erection has to be 4 hours. So the caveat, the one thing I will say is I put almost all of my patients on a low dose tadalafil, 5 milligram daily dose tadalafil. And that's because I think it's good for penile rehabilitation. So by the time that somebody, at least in my office, starts on injection therapies, they're already on a daily dose tadalafil, 5 milligrams every day, because it's good for penile rehabilitation. So when we're starting the injections, they're already on that medication. The worry would be you do an injection and you say, you know what, it didn't really work out with this injection. Let me take that 100 milligrams of sildenafil or 20 milligrams of tadalafil, because if that kicks in, now all of a sudden you can end up in the emergency room because the penis is not going to want to go down. So can it be done? Yes. Can it be done safely? Yes. Is it kind of redundant? And because really the ideal thing is just simplify your life. Find that concentration that works best for you with the shots if the pills aren't strong enough. Unless you need it, because let's just say your erectile dysfunction is too severe, or you're on something like a daily dose for rehabilitation reasons.
All right, next question here. We actually saw this one asked a couple different ways during the registration question submission, but here it is. When I orgasm, I don't ejaculate. Why? And has the well gone dry?
The well has gone dry, more than likely. So there's there's 3 parts to having sex. We'll say 4 parts. Number 1, desire, libido, all right? We know a lot of that's heavy, really has to do a lot with the hormonal side, the andrology side, the testosterone side. Number 2, the erection, getting rigid, getting and staying hard. Number 3, the orgasm, which is a violent contraction of the muscles of your pelvis when you reach that climax. Number 4, ejaculation, something coming out of your penis when you go, and that's something should be ejaculated because some guys, unfortunately, they can have some urine for different reasons come out. So we're very good at fixing libido. We're very good at fixing erections. We had a whole webinar about that. Orgasms a little bit better. Some, unfortunately, ejaculations, depending on the reason. So common things, medication side effects, the more common one we give is something like Flomax, tamsulosin. Surgery, if you take somebody's prostate and seminal vesicles, let's say, because they had prostate cancer, well, 80 to 90% of the ejaculate comes from the prostate and seminal vesicles, and ultimately the other 10% comes from the testicles, which when that goes, there's no way to get the stuff from the testicles to the ejaculate. In that case, forget the well going dry, the well's been removed completely. So it's a little tougher. It's something, again, you should see a urologist about that subspecializes in this because it's a little more subspecialized. And just looking at a lot of times medications and the surgical history may be able to answer that question.
All right, next question here. How can you travel effectively with injection medication? I have a 13-hour flight coming up.
Yeah, so like any other medication, it's safe to take, and the TSA will not take this from you. You know, the beauty of the tote, I really like the little tote that MNMD provides. You could put a little ice pack in there and keep it in there. Definitely don't recommend throwing it in your check-in bag, and because they're just going to throw that on the bottom of the plane, and it's going to be hot as hell. By the time you get to wherever you're getting, it's probably going to be an inactive medication. So travel with it the same way you would travel, let's say, insulin or any other medication that needs to be refrigerated.
All right. Next question here. I've tried the Viagra, Cialis, and even injection medication. I get a soft erection, but not hard enough for penetration. Do I need a stronger or different mix of injection medication? What are my options beyond medication?
Yeah, so when somebody comes to me with erectile dysfunction, I tell them there's 4 treatment groups. Least invasive to most invasive. And again, this isn't I didn't come up with this. This was created by men and women who are much smarter than I am, again, the American Urologic Association. 4 treatment groups from least invasive to most invasive: pills, Viagra, Levitra, Cialis, Tax, and Stendra; gels, intraurethral gel therapy, which again, there could be a whole other webinar on that, which is similar medication, but instead of injecting into the penis, you're absorbing to the urethra. The injection, which we just talked about, and then a penile implant. Those are your 4 treatment groups. And really, as the guide, I'm walking patients through this until they get to the point where they're happy. So if pills weren't enough, you jumped into the shots, to the injections. The injection that you're using right now is not enough. Well, your real options are go up in the dosage, go up in the concentration, or proceed with a penile prosthesis. That's really where you're at if that's the case, because that just means that you need something that's stronger.
All right. Got another question here that's been asked a couple times. Can you use a VED or penis pump with trimix or injection medicine?
Yeah, the VED I think is an extremely versatile tool. The other thing I tell my patients is I'm providing the rules of engagement and the weapons. Other ones going to war. So one weapon which is great is a vacuum erection device. People can use it for rehabilitation purposes to try to regain what they've lost. Some guys will use it to have intercourse. They'll use a vacuum erection device. They could put a ring on. I know MNMD provides those as well. And so, yes, you can use it with an injection therapy. You can almost throw that into any type of treatment option that you have: pills, gels, injections. With an implant, you will need it, but with the other ones, you can use that in combination. Absolutely.
All right. And a follow-up to that is, what do you use first? Do you inject first, or do you use the VED first?
Doesn't matter. Some guys will do the VED first because, especially depending on how big their bellies are, it can be a little more difficult to pull the penis out. If you use a VED, you may have some erection or a more rigid penis or a longer, thicker penis that then will allow you to be able to inject a little bit easier. You should be careful with putting the ring on, because if you inject, then that will limit some of the blood flow there. Some guys will inject and then they use the vacuum to get things going and they put a ring on. But whether you use it before or after doesn't really matter. You can experiment with it and see what works better for you.
All right. Next question here. Can injections cause permanent penis curvature? I've noticed my penis starting a curve where I inject.
Yeah, again, this goes into the Peyronie's disease or the scar buildup. If you start seeing that, my advice is inject opposite to where the curve is at, because what you'll do is you'll actually straighten out your penis that way. You gotta spread the love. Don't inject in the same place over and over and over again. Another benefit of being on a rehabilitation protocol like your low-dose Cialis combination with maybe a vacuum device, you can help prevent this plaque buildup, and or if you have it, you can help treat it. And so, yes, that can happen. And those are some of the tricks of trying to improve it and or straighten out the penis.
All right. Next question here. For me, it hurts to inject. Is this due to improper technique? What are the best ways to avoid pain while injecting?
Again, it goes back to, I think, the first question that was asked. It could be either poor technique, so that's, again, something that's incredibly important to go over with your urologist, or it could be that the mixture maybe just has too much prostaglandin in it, something that, as I said, can be very vasoactive, but can also be very bothersome. And so that's something that you're going to want to discuss, because there may be some things you can tweak to try to improve some of the discomfort that you're experiencing.
All right. How long can one stay on injection medicine and be an effective treatment?
Indefinitely. If it works, if it ain't broke, don't fix it. So if it's working for you, stick with it.
Awesome. I've noticed that my injections have been decreasing in effectiveness. Over 3 years, I have gone from an erection that lasts 1 hour to less than 15 minutes while increasing the dosage. Do I need to try a different mix, or is ICI therapy no longer a good option for me?
That's a very personal question. And as I stated before, it's inevitable the erections are going to get worse. This is just a process of aging. And you can go up in the concentration, the dosage, or at some point, if you say, you know what, this is not for me, then your other options are combination therapy. So you can try a phosphodiesterase inhibitor with a gel and see if that works, or you proceed with down the algorithm and proceed with the surgical treatments.
All right. Is injection medication covered by insurance?
No, unfortunately, it's not.
All right. Next question here. We've actually got a few questions around the medication effectiveness and how long the shelf life is for that. So here's the first question. The clock doesn't start ticking until you puncture the vial, correct? What is the shelf life of the unopened vial?
Yeah, that's a good question, actually, and I'm not quite sure. I don't know if Austin, if you have that from the and the beautiful thing about MenMD is you can actually call and talk to a pharmacist to discuss the actual shelf life of this. Now, you know, if a patient has it and they've had it for maybe a month or two, maybe 3 months, I tell them they can go ahead and use it. If they've had it for a year or two, you're not talking about a bottle of French Bordeaux wine. It's not going to get better with age. And once you puncture it, 28 days is what they recommend. So.
Yeah, definitely. And I'm not a pharmacist, so I can't tell you the exact reasoning behind it, but it's all for your safety. We'll just put it that way.
Correct.
All right, next question here. When I inject, a pocket of medication forms on the side of my penis. Am I doing something wrong?
So when you inject, they have a little bump on the side of the penis. Is that did I understand that correctly?
Yes, I believe that's the question.
Yeah. So again, it's either the medication itself that didn't go all the way into the corpora, or it could be a hematoma, a little bruise from the injection.
All right, next question here. What happens if the injection doesn't work after 10 minutes or so? Can I inject again?
No, recommendation is not to inject again because, again, it's not recommended to inject more than once in a day. Number two, the worry is that there's a little delay in the medication. Now, all of a sudden, you got extra medication in there, and that extra dose will unfortunately can unfortunately cause the patient to develop a priapism erection, an erection lasting more than 4 hours.
All right, and speaking of that, I tried injection therapy 2 times, and both times it sent me to the emergency room. Is there a preloaded needle or dosage available that would be a better option?
Yeah, again, that's the importance of doing this in a controlled setting. This is why I like doing a Doppler on everybody, because based off of what I see in the blood flow, I'm going to be able to decide, should this patient be on a low concentration bimix versus a very high concentration trimix 16. The worry here is what some guys say that's not a worry, but it is because going to the emergency room with an erection lasting more than 4 hours, it's not fun. And so really the ideal thing would be to sort of, if that happens, you want to sit down with your urologist again. Hopefully you did go to a urologist and it wasn't just some of these places where it's like the wild, wild west. They just give you something there and they don't really evaluate you completely. But you want to try to find that sweet spot of working your way up little by little until you get to that erection that's rigid and sustainable enough for the entire sexual intercourse, but lasts less than an hour, okay? And so, yeah, you may have to change the concentration, something weaker, maybe go down the dosage. These are all things that should be considered.
All right, next question here. I've noticed that in the morning, when I have intercourse, I only have to inject half the amount of my trimix compared to when I have intercourse at night, where I have to inject the full dose. Why?
Erectile dysfunction or erection, again, the stars have to line it. This is a multifactorial issue. Typically at night, let's say, somebody's tired, somebody's stressed, your body's not going to respond the same that it would if you were refreshed early morning. Some guys may also be taking some extra medications, like a Cialis in the morning or a Cialis at night. They may be seeing some of the effects of this. And so you may have better times. I mean, who said you have to have sex at night? Some guys prefer to have sex in the morning because of that, because they'll see some better response to it. And so that's a very common thing that I'll hear, actually. And I think it's perfectly reasonable. And this is where the patient, you as a patient, you become the expert. You're going to know your body. You're going to know, hey, you know what? Even another interesting change in dosage would be when I first crack the bottle open, I need only 5 or 10 units. At the end of the 28 days, I need about 10 to 15 units. And so you'll find these differences in the dosages based off of a lot of different things, including the time of the day.
All right. Next question here. Does alcohol impact injection medication?
Yes and no. So sometimes, depending on how much alcohol you have, some guys, if they drink a lot, it's going to be tough to work even with the injection. The good thing with the injection is you can be in the middle of a church with the ugliest person in the world. A lot of times, because this stuff is very vasoactive, it may still give you the erection. But yes, it does have an effect. It's not contraindicated. You can have an alcoholic beverage or even more than one with these injections. But if you overdo it, you may potentially see some negative side effects. And of course, if you drink too much, sticking a needle in your penis always seems a little more difficult. So you want to be careful with the amount of alcohol that you're ingesting.
All right. Next question here. Why does the injection medicine only work when standing up? When I lay down, my erection goes away.
When you lay down, and this is actually the most common position, partner on top, it's probably one of the most difficult positions for a man with erectile dysfunction to be able to accomplish. Why? Well, because of gravity. When you're laying down, the penis is standing up, and all this fluid will hold here the model. Now all of a sudden, all that fluid, all that blood, the gravity's taking it back down. You don't have anything to help it, as opposed to standing where you got all this pressure, all the fluids coming towards the penis. And so that's a tougher position to be able to sustain a good rigid erection because unfortunately you got gravity working against you.
Our next question here. I have many areas where there is subdermal scar tissue from former injections. How do I guarantee injection into the corpora cavernosum without hitting scar tissue?
You got to know your penis. You're going to have to know the anatomy. You got to know where your scar is. You're injecting a scar, you're not going to get into the corpora cavernosum. So again, the importance of spreading the love. If you got your penis, you know, hey, I got a big dense scar here. Well, let's start injecting over here. Over time, hopefully that scar will get softer. You'll be able to start injecting again there. But yeah, you want to probably stay away from these dense scars because you're not going to see the same efficacy of this medication if you inject into a scar than you do into an actual virgin or good, soft, supple tissue of corpora.
All right, next question here. I feel a lot of apprehension when injecting myself. How can I overcome this? How have others overcome this?
Yeah, so the apprehension, again, experience, feeling comfortable having these sort of sessions with a urologist where they can teach you technique. The other beautiful thing that I think MenMD provides is this auto injector. Makes it a lot easier. This makes it pretty much foolproof. It'll allow you to be able to do this without worrying about not having good dexterity or you don't see the needle if you're needle phobic because it's hiding within the actual sheath of this. And so, number one, practice makes perfect. Number two, having somebody that's guiding you is incredibly important. And number three, having the right tools to be able to get over that hump of being afraid is key.
All right. Next question here. Is this type of therapy as effective with patients who have had several stents put in the groin area?
So any therapy is going to be less effective in somebody who's had stents because that technically by definition makes the patient what we call a vascular path. In other words, you have plaque buildup depending on the region that you had the stents placed, but if it's because of plaque buildup, you're not only going to have it in the arteries of the legs or the heart, you're also going to have it in the corporal arteries. And so those men tend to have worse erectile dysfunction when compared to others that don't have stents. So depending on the reason why you have the stents, it may not be as efficacious. You may need to be on a higher concentration or a higher dosage in order to be able to have the desired results.
All right, we're getting close to 7 o'clock here, so we've got time for a few more questions, depending on how quickly we get through these. But next question here is, does long-term injections shorten your penis length? So,
Unfortunately, Father Time or Mother Nature, whichever one, I don't want to sound sexist, but that's really the culprit of shortening penile length. As we get older, the joke in urology is the penis gets bigger, or the prostate gets bigger and the penis gets smaller. So yeah, you can develop some shortening of the penis with plaque buildup, but you got to have a lot of plaque buildup in order to have the penis to get shorter. So if a man notices, hey, my penis is shorter now, I wouldn't blame it so much on the injection. I think I look at number one, gut size. 10 pounds equals an inch, another joke, but again, that's there is some truth to it. If you've had something like a prostatectomy, unfortunately, you had removing your prostate can also shorten the penis. But really the goal to regaining size, length, and girth is having good erections. And so you may develop some scar tissue from the shots, but I think that the actual erection itself far outweighs the benefit of having it, far outweighs the actual scar that you may develop from putting a needle into the penis.
all right, got a very topical question here. How safe are injections with this COVID-19 pandemic?
I guess it depends on who you're having intercourse with, and if you're having multiple partners that you don't know where they've been at and you haven't been in quarantine with them, you got to be careful. You may want to consider maybe even having intercourse with an N95 mask. But shot-wise, you're not going to get COVID-19 from having an injection to the penis. So I think the injection itself is not what's going to give you COVID.
All right, that's good to hear. Is there a way to decrease bruising after injections?
Bleeding?
Bruising, so.
Bruising, yes. So bruising, bleeding, yeah, that's the key. The key there is the pressure. Number one, making sure that the superficial veins, you're not going through a superficial vein. And number two, it's holding a little pressure there, 2, 3, 4 minutes, depending on your history, potentially if you're on Plavix or Coumadin or one of these anticoagulants. So you want to hold a little pressure there too.
All right, I think that's going to be the last question for the event. We're butting up to 7 o'clock here. So with that, I'd like to thank Dr. Martinez for taking the time to present today. And we'd also like to thank everyone listening in for attending this MinMD Real Talk webinar. We hope it was informative, and you'll join us again in the future. If you'd like to learn more about injection therapy, you have a few options here. As I mentioned in the introduction, we've attached the injection therapy guide to this event. If you'd like, you may download the PDF for your reference later, and that is going to be in the handouts tab again. There are also more resources in the resource center on minmd.com. Visit this page to view instructional videos, guides, expert articles, and a lot more. You can also call MinMD at 857-233-5837 or log in to our password-protected secure MinMD portal, and there you can schedule an appointment with a MinMD clinical case manager. If you're interested in any of the injection accessories Dr. Martinez went over today, you can learn more or purchase the accessories on the shop page in the MinMD portal. We'll also be sending a follow-up email with references to helpful resources and links to each after the event. So with that, I'd like to thank everyone again for attending today's webinar, and we will see you at the next one.